Okay, so this is another teaching station. This is a simulated trainee task assessing communication with colleagues, patient safety, and applied clinical knowledge. You will see a year 4 medical students who wants to learn more about the mechanism of normal labor. Please teach her and support her ongoing training. So first of all, you will introduce yourself by name and role, welcome her, and then ask her, like, how is your study going on, and offer your help and support. So if you feel any difficulty or you want more explanation about any topic, you feel it difficult to understand, please don't hesitate to contact me at any time. And then you ask her why she wants to learn about normal labor, and then appreciate her interest and so on. So as any teaching station, then you put a plan. Okay, you tell her, so we are going to speak about the mechanism of normal labor, and we will discuss some diameters of the fetal skull and some diameters of the maternal pelvis, and then we will demonstrate everything with like a doll and a pelvis. And then if you feel at any point that you need me to repeat anything, or you have any question, feel free to stop me at any time. Okay, so going ahead, so first of all we need to know what are the diameters of the fetal skull. So we really need to know about the transverse diameters. We have the biparietal diameter, which is connecting between the furthermost points on both parietal bones, which is shown here as 9.5 centimeter, and this is the largest or the widest transverse diameter. And when this area passed through the pelvic inlet, we can tell that the head is engaged. We have another transverse diameter, which is bitemporal one, which is 8 centimeter. It's not important in the mechanism of normal labor, but we need to know it as one of the transverse diameters of the fetal head. Okay, so that is the transverse diameters of the fetal head. We have longitudinal diameters. We have what we call suboccipito-pragmatic. That is the most important one, which is 9.5 as well. And this is the diameter connecting the suboccipital region to the anterior fontanelle. The anterior fontanelle is called a pragma. So the suboccipito-pragmatic means it's connecting from the subocciput area to the anterior fontanelle, and it is also 9.5. So if the longitudinal diameter is suboccipito-pragmatic and the transverse diameter is biparietal diameter, so it will be 9.5 times 9.5. So it will be like a circle. Okay, and these are the diameters when the presentation is vertex. We have other longitudinal diameters which can be presented in different flexion, different position of the fetal head, like occipitofrontal, which is the 11.5 centimeter, which is connecting the occiput to the frontal bone or the supraorbital margin. That's 11.5. It's little bit bigger than the suboccipito-pragmatic, and this is in case of deflexed head or occipito-posterior. And we have also the mento-vertical, which is happening in brow presentation. That's 13.5, which cannot pass the pelvic inlet. Okay, so it is undeliverable. So that is the important diameters really in the fetal head. So again, we need to know about transverse diameter, the biparietal, which is 9.5, and suboccipito-pragmatic is 9.5 as well. And if you tell these two diameter, I think that will be enough. Okay, so coming to the pelvis, the diameters of the pelvis, we need to know about the pelvic inlet and pelvic outlet, and the cavity. The cavity is all the same, it's 12 centimeters, so the cavity is like a circle, and that's why the internal rotation happens in the pelvic cavity, because it's a circle. There is nothing to resist the head rotation. So the internal rotation should happen in the cavity when all the diameters are equal, which is 12 centimeter. So it will happen smoothly without any resistance. Okay, so the pelvic inlet is an oval shape where the transverse diameter is bigger than the anteroposterior. The transverse diameter is 13 centimeter. The anteroposterior is 11 centimeter. If you look at the pelvic outlet, it will be the opposite. So it is also diamond shaped, where the anteroposterior diameter is bigger than the transverse diameter. So don't worry, I will show you soon on the pelvis all the diameters. Okay, so the anteroposterior diameter of the outlet is 13 centimeter and the transverse is 11. So it's the direction is opposite between the inlet and the outlet. So if the head enters the inlet from a specific diameter, it has to rotate inside and come from the outlet from the opposite direction. And the head tends to enter the pelvis through the biggest diameter and come out of the pelvis through the biggest diameter, because that is easier. Okay, so it should enter the pelvis, the pelvic inlet, through the transverse diameter and come out from the outlet through the anteroposterior diameter. I will show you soon with the doll and the pelvis. Okay, so let's speak about the events or the mechanism of normal labor. We have first of all the descent. So because before engagement the head is floating in the abdomen, so the head has to engage first in the pelvis and then to descend furthermore. So first of all, the head has to engage. The engagement, as I told you, when the greatest transverse diameter pass through the pelvic inlet. Okay, when the biparietal diameter pass through the pelvic inlet, that's engagement. After engagement, the head has to descend furthermore, continuous descent inside the pelvis. So the descent has to face a resistance from the pelvic floor muscles, especially the levator ani. So it will cause increased flexion of the head, so like a counter action. So when the head is engaged and then descent, the levator ani will counteract this descent, causing the head to be more flexed, and that will bring the least diameter, which is a suboccipito-brygmatic. Okay, so again, first of all, engagement, then descent, then increased flexion by the order like that. So descent, no, engagement, descent, increased deflection. Once increased deflection happen, the head will go for the internal rotation. Okay, so the internal rotation should bring the occiput below the symphysis pubis in case of occipito anterior position, or it will rotate on the opposite direction to bring the sensibut below the symphysis pubis. That's in case of if the baby presented with occipito posterior position. But what I mean that it will be coming to be ready in the longitudinal diameter of the pelvic outlet. Okay, so internal rotation will happen, and then with further contractions the head will come out with extension. Okay, and once the head comes out, it will rotate back again. We call it restitution, so it will return back to its original position before internal rotation, and then it will further rotate externally. We call it external rotation to deliver the to bring the anterior shoulder in the anteroposterior diameter to be delivered. So once the anterior shoulder is delivered, then the posterior shoulder will be delivered by bending, like, you know, if you guard the head upward like that, the posterior shoulder will come. Okay, so again, first of all, engagement, then descent, then increase deflection, then internal rotation, then extension, then restitution or external rotation, then delivery of anterior shoulder, then delivery of the posterior shoulder. The rest of the body will come easily without any difficulty. Okay? So when we start to know the diameters of the fetal heads, we need to know the landmarks. So this is the anterior fontanelle and the coronal suture, sagittal suture. Here is the posterior fontanelle and lambdoid suture. This area is called the subocciput because here is the occiput. Okay, so this is the subocciput where we start from, and here is the supraorbital margin, and these landmarks are for the vertex of the skull. So we have some longitudinal diameters and some transverse diameters, and the main transverse diameters, all we know, is the biparietal diameter, which is 9.5 centimeter. We have another smaller one, which is the bitemporal one, which is here. And longitudinal diameters, we have many of them, like starting from the subocciput maybe to the frontal or to the prigma, which is the anterior fontanelle, like here. It depends on the degree of flexion of the fetal head. So if it is like a deflexed head, it will be like occipitofrontal or suboccipitofrontal is the longitudinal diameter. However, if it is like fully flexed like that, so the suboccipitoprigmatic will be the longitudinal diameter. Okay? So when we speak about the landmarks of the pelvic inlet, so we need to know the anteroposterior diameter and transverse diameter. So the anteroposterior diameter, which runs from the promontory of the sacrum to the upper border of symphysis pubis, and the transverse diameter, which runs between the two farthest point here. So the anteroposterior diameter is 11 centimeter and the transverse is 13 centimeter. So the transverse is bigger than the anteroposterior, and this gives us the oval shape. And the opposite happen in the outlet. So in the outlet, the anteroposterior diameter is bigger, so it is 13.5 centimeter from the coccyx to the lower border of symphysis pubis, and the transverse diameter is 11 centimeter, which is intertuberous diameter, and these are the ischial spines, which are also the landmarks. So that is the difference between the inlet and outlet. So we are going to quickly show how the events in normal labor happens. So first of all is the engagement. So as you can see, the head has to enter the pelvis through the transverse diameter and come out from the outlet through the anteroposterior diameter. Okay, so first of all, engagement, which is when the greatest transverse diameter go or pass through the pelvic inlet. As you can see, it's easier through the transverse than the anteroposterior, so it can't be the anteroposterior diameter here. So it has to go like that through the transverse diameter and to do in like internal rotation inside, and this will bring the occiput below the symphysis pubis in the anteroposterior diameter again. So first of all, the head has to do engagement and then descent, and to increase its flexion and then internally rotate. So again here, the engagement, descent, increase deflection and internal rotation. So now it is ready in the anteroposterior diameter of the outlet. So with further contraction, the head will go for extension and will be delivered. So the head will be delivered by extension, like that. And then the head has to restitute, like rotate again to retain its original position and do external rotation to bring the shoulder in the anteroposterior diameter to be delivered.